Okay, folks, let's go. So preterm birth, questions that misunderstood, confused you on big exams, board exams, and let's go. Preterm birth. Take your pens, papers, and let's go. My beloveds, preterm birth is a syndrome. It's not a disease. It's not a single disease, okay. So preterm labor isn't caused by one thing. It represents the endpoint of multiple pathological pathways, including infection, inflammation, for example, intraamniotic infection, decidual hemorrhage, abruption, uterine overdistension, twins, polyhydramnios, maternal fetal stress, premature cervical ripening, and placental dysfunction. Placental dysfunction. Many cases remain idiopathic despite investigation. Idiopathic means unknown. Many cases around 50%, half. What is clinical importance of that, my beloveds? This heterogeneity explains why no single preventive strategy or treatment works for everyone. Clinicians must consider the likely underlying cause when managing a patient. For example, antibiotics are a key for preterm premature rupture of membranes with suspected infection, but not typically primary treatment for preterm labor with intact membranes. So research focuses on identifying pathway-specific biomarkers and therapies. Next, subclinical intraamniotic inflammation is a major, often silent driver. Many women presenting with preterm labor, especially at early gestation, means less than 32 weeks, and those with preterm premature rupture of membranes have microbial invasion of the amniotic cavity or intraamniotic inflammation, often without classic signs of infection like fever or maternal tachycardia. Organisms can ascend from the lower genital tract or, less commonly, arrive hematogenously. Clinical importance. This highlights the rationale for Group B Streptococcus screening and intrapartum antibiotic prophylaxis. In preterm premature rupture of membranes, latency antibiotics are given to prolong pregnancy and reduce neonatal infections morbidity. It also underscores why routine antibiotics for preterm labor with intact membranes haven't shown clear benefit, because the infection may be inaccessible actually, or inflammation may be sterile. Inflammation might be sterile, yes. So amniocentesis can sometimes be used in research or complex clinical scenarios to diagnose microbial invasion of the amniotic cavity or intraamniotic inflammation. About cervical length measurement is as a powerful predictor. Transvaginal ultrasound measurement of cervical length in the mid-trimester, that is around 16-24 weeks, is one of the strongest predictors of spontaneous preterm birth. A short cervix, typically defined less than 25 millimeter, indicates a significantly increased risk. Clinical importance. This allows for risk stratification. Identifying women with a short cervix enables targeted interventions like vaginal progesterone supplementation or cerclage placement. Placement is stitch placed around the cervix. Both proven to reduce the rate of preterm births in specific high-risk populations. For example, women with a history of preterm labor at a short cervix or is incidentally found short cervix. Okay? Now about this fetal fibronectin testing. It's a high negative hazard. This fibronectin test has a negative predictive value. Fetal fibronectin is an extracellular matrix protein acting like glue at the maternal-fetal interface, so-called choriodecidual junction. Its presence in the cervico-vaginal secretions between 22 and 34 weeks suggests disruption of this interface and it increased risk of impending preterm delivery. Clinical importance. While its positive predictive value is modest, a negative fibronectin test is highly reassuring. In women with symptoms of a preterm labor but minimal cervical change, a negative fibronectin test strongly indicates that delivery within the next 7-14 days is unlikely. This helps clinicians avoid unnecessary hospital admissions, interventions like, tocolytics or steroids, and patient anxiety. Okay? About steroids, hormones. So, antenatal corticosteroids are life-saving, but timing matters. A single course of corticosteroids, that is betamethasone, dexamethasone, given to mothers at risk of preterm delivery between 24 and 34 weeks gestation is one of the most effective antenatal interventions. Actually, we can say it's a beginning of evidence-based medicine. Cochrane science, Cochrane symbol, it's this. It's for actually first that enters in the Cochrane library. It's about corticosteroids given in preterm labor. So preterm delivery. Actually, we know that these hormones accelerates fetal lung maturity by stimulating surfactant production. So what is clinical importance? Antenatal corticosteroids significantly reduce the risk of neonatal respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and overall neonatal death. The benefit is greater if delivery occurs in gap 24 hours up to 7 days after administration of these steroids. Current guidelines often extend recommendations, consider antenatal corticosteroids for threatened preterm labor up to 36 plus 6, so-called late preterm, and even for planned late preterm, C-sections. Repeat courses are generally not recommended routinely due to potential long-term neurodevelopmental concerns. Though rescue thus may be considered in specific situations. About magnesium, my beloveds, magnesium sulfate, of course. Magnesium provides fetal neuroprotection. While once used primarily as a tocolytic, that is to stop contractions with limited efficacy and significant side effects, magnesium sulfate administered to mothers at high risk of imminent preterm birth at early gestation, less 32 weeks, sometimes less 30 weeks depending on protocol, has a proven neuroprotective effect on the fetus. Clinical issue. Magnesium sulfate significantly reduced the risk and severity of cerebral palsy in surviving preterm infants. Thanks God. The mechanism isn't fully understood, but it may involve stabilizing cerebral blood flow, reducing excitotoxic injury, and anti-inflammatory effects. It's now standard practice to administer magnesium sulfate for this indication when very preterm birth is anticipated, independent of its use for seizure prophylaxis, eclampsia, preeclampsia. Then, about tocolytics. Tocolytics, my beloveds, buy time but not prevent preterm birth. Medications used to suppress uterine contractions, tocolytics, such as nifedipine, it's a calcium channel blockers. Indomethacin, it's a non-steroid anti-inflammatory drugs, typically less than 32 weeks due to ductus anteriosus concerns. Ductus anteriosus concerns, or terbutaline. Terbutaline is a beta agonist, short-term use only, of course. So these tocolytics do not significantly reduce the overall rate of preterm births or improve long-term neonatal outcomes. So what is clinical issue, clinical importance? The primary goal of tocolytics, usually for up to 48 hours, is to delay delivery long enough to allow for the administration and maximal benefit of antenatal, mentioned above, corticosteroids, and, if needed, transfer the mother to a facility with appropriate neonatal intensive care unit capabilities. They are not a long-term solution. Choosing the right tocolytic depends on gestational age, maternal comorbidities, and side effect profiles. Next, progesterone. Progesterone supplementation is effective prevention, but only for specific groups. So despite progesterone being crucial for maintaining pregnancy, progestation, its role to preventing preterm labor is specific. Supplementation, either vaginal progesterone or intramuscular 17-OHPC acronym, 17-OHPC, has shown benefit only in women with a prior history of spontaneous preterm births or those identified with a short cervix in the current pregnancy. Clinical issue: progesterone is not effective for treating active preterm labor, preventing preterm labor in a multiple gestation, twins, triplets, or preventing preterm labor in a women without specific risk factors. Clinicians must correctly identify eligible candidates to maximize benefit and avoid ineffective treatment. The mechanisms likely involve anti-inflammatory effects and promoting uterine quiescence. Now about term definition of viability. So definition of viability is evolving, creating some ethical dilemmas. Advances in neonatal care have pushed the limits of viability to increasingly earlier gestational ages, now often considered around 23-24 weeks, and sometimes even 22 weeks in specialized centers, of course. However, survival at these peri-viable gestations comes with extremely high risks of severe long-term morbidity, neurodevelopmental impairment, chronic lung disease, blindness, deafness, God forbid. So clinical importance: managing threatened preterm labor at the age of viability, approximately 22-25 weeks, requires complex multidisciplinary counseling involving obstetricians, neonatologists, and the parents. Discussions must balance the potential for survival with significant risks of severe disability, incorporating parental values and wishes into shared decision-making regarding resuscitation and intensive care. Hospital protocols vary, but God bless these parents. So preterm birth carries significant long-term health consequences and disparities. The impact of being born preterm doesn't end at a neonatal intensive care unit discharge. Preterm infants are at a high risk for long-term neurodevelopmental problems, learning disabilities, attention deficit, hyperactive disorder, cerebral palsy, respiratory issues, asthma, for example, cardiovascular problems, hypertension, all spectrum of metabolic syndrome, visual and hearing impairments extending into adulthood. Furthermore, significant racial and socioeconomic disparities exist in preterm birth rates and outcomes. So clinical importance: clinicians must be aware of these long-term risks for counseling parents and ensuring appropriate long-term follow-up and support services. Addressing the root causes of disparities, including systemic racism, access to care, and social determinants of health, is a critical public health challenge that physicians should be aware of and advocate for improving. So that's all concerning misunderstood questions. These several previous years. The questions that confuse you on the big board exams, I hope it will be helpful on your big exams, not actually on your big exams, on your future medical practice as well, I hope. So, thanks for your attention. See you. Yes, don't forget to follow and subscribe my Dr. Y YouTube channel and especially my Telegram Dr. Y channel, if you want. It's a private. So you might, what does it mean private? Private means payable, and private, closed channel. So how to subscribe this channel? You tap in searching mode. In Telegram, Dr. Y, W-H-Y, Dr. Y is me. W-H-Y, without question mark. Actually, W-H-Y like question, Dr. Y. You find this boat, you click start, you choose your plan, and we will talk. Choose the cheapest one, for months, for example, monthly. And we will find the questions like this, questions, answer, videos, students' cheat sheets, yes, why not, gifts, presents, clinical cases, interesting clinical cases, and so on. MCQ tests, actually, yeah, in each domain, obstetrics, gynecology, my internal medicine, surgery, question, answer, explanations, oral exams, questions, etc., etc., etc. So see you on my Telegram Dr. Y channel. Stay blessed.